Alright, I'm going to cover hyper and hypocalcemia. This is going to pale in comparison to anything you're going to see on Dr.
Here's
Eric
what his
Strong's
page
page.
is gonna look like
if you get to his
page
page, watch his videos on calcium and phosphate metabolism. So anyhow, the overview of the physiology. Where does everything come from? So we get calcium in our blood. Where does it come from? So the calcium comes from the GI tract. It's absorbed into the blood. It's stored also in the bone, so from the bone is like a reserve that can buffer the calcium in the blood. It gets kicked out through the kidney, and you have the hormones of the parathyroid and also vitamin D from exposure to the sun and also vitamin D from your diet that's all responsible for that. Alright, so the hormones involved, what do they do? So each of the hormones, you got the parathyroid hormone. It's going to act on the bone, kidney, and blood. It's going to raise blood calcium. You've got vitamin D that's going to act on all three, the GI tract, the bone, the kidney, and it's going to increase blood calcium. And then calcitonin, I only mention it because it can be used as a treatment. Physiologically, it's not important at all. People that have tumors of the thyroid gland, people that have thyroidectomies, the calcitonin change does not affect their calcium homeostasis. And so no one really knows what the purpose of calcitonin is, but it can be used super physiologically, and so it causes bone resorption. It decreases bone resorption, and like I said, no physiologic effect. It has supraphysiologic effects whenever it's in supraphysiologic concentrations. Alright, the clinical presentation of hypercalcemia, the classic. So this is memorized by the mnemonic: stones, bones, groans, and psychologic overtones. Stones is referring to nephrolithiasis. Bones, you get bone pain. Groans, you get abdominal pain. Psychological overtones, that's depression, anxiety, and confusion. However, there are some other presentations that aren't the classic, and those can be remembered by eating, excreting, and energy. Eating refers to anorexia. Excreting can refer to a number of things. You're going to get constipation, you can get emesis, polyuria, and then you can also get post-renal failure. So of all of these, so if you think of food just going out the wrong way instead of the right way, that covers this. And then the polyuria and the and the post-renal failure would kind of contradict each other. You get polyuria because you can get an induced nephrogenic diabetes insipidus, but the post-renal failure is if you get a stone in like the ureter, it's going to cause a backup of urine, and so then of course it would slow down urination. So eating, excreting, and then energy refers to lethargy and weakness. None of these are really sensitive or specific for diagnosis. There is something that is pretty interesting though. So for example, this long QT interval, this was taken from lifeinthefastlane.com. I didn't obtain any permission to use this, so hopefully no one cares. But the hypocalcemia is very sensitive and specific for the long QT interval. I saw several papers published in the 1980s that basically worked out the sensitivity and specificity for these. So this is the QT interval. So you got the QRS complex, and then you have the T wave, and so you have a really shortened QRS complex. Now, whether you measure this from the beginning of the T wave, the middle of the T wave, or the end of the T wave is going to affect your sensitivity and specificity. So I think from the papers that I read, the best specificity is if you measure it from the beginning or middle of the T wave, and you become more sensitive if you measure it from the end of the T wave. So specificity, beginning, sensitivity, ending. Alright, so again, overview. What's going to cause an imbalance to cause the hypercalcemia? The first thing is you got calcitriol that's going to act on the GI tract. That's vitamin D. It's going to absorb calcium into the blood, and it's going to act on the bones to put calcium in the blood, and it will also act on the kidneys. Then you have parathyroid hormone that will also act on the blood and on the kidneys, however not on the GI tract. Then, of course, I mentioned calcitonin. Again, it needs to be in pharmacologic doses. So the etiology would be anything that messes up the GI tract, the bones, the kidneys, the blood, or the hormones. So all the things involved can be part of the etiology. And so With hypercalcemia, we have major classifications. You have your excesses, excess of PTH, excess of vitamin D, excess calcium ingestion, excess thyroid hormone. This one's kind of weird, I'll explain it. Then you have other crazy endocrine problems, and then you have non-endocrine and non-ingestion, and then you have medications and other. So PTH excess, what is this about? You can have a primary or a tertiary. In secondary, you're going to get hypocalcemia. So you get hypercalcemia with primary and tertiary. What does that mean? So an adenoma of the parathyroid gland, hyperplasia, or carcinoma, these things will cause an excess PTH, and that will follow up and cause excess calcium. If you also have long-term renal insufficiency to the point where you get hypocalcemia, you'll get like a rebound hyperparathyroidism, and that can result in hypercalcemia. There's drugs. Lithium will inhibit the Kassar gene, the Kassar protein receptor. With the Kassar stands for calcium sensing receptor, and this is found in primarily in the kidneys and in the parathyroid gland. I'll cover exactly how it works in a little bit. Ectopic PTH. It's PTH. This is pretty rare to have ectopic PTH, but it is not rare to have PTHRP, which is parathyroid hormone parathyroid hormone related protein. So that's not very rare at all. It's actually in many tumors. And then you have the Kassar mutation, which can cause familiar hypocalciuric hypercalcemia. So it's basically just a mutation that you can pass along. It's rare, but it's highly tested, as we all found out in Block 1, and as Dr. Eric mentions, and as a few other sources I've seen will mention, this is highly tested. May see it again in the future. Sometimes it's caused by a G protein. So the Kassar mutation will cause familial hypocalciuric hypercalcemia, or in even rarer cases, it's caused by a mutation in the G protein that's attached to the receptor. All right, so let's look at this really quick. This is the Kassar gene in the kidney. Basically what it does is it will bind, and then it will prevent aquaporins from being inserted into the lumen. And so when it prevents that from happening, you don't get water reabsorption, so you got more water coming out here. And the other thing that it does is it will cause a reaction to pump out protons. And so basically what this does is it prevents the calcium from turning into a calcium salt and causing stones. And so it in normal cases, calcium does not alter either the fluid pumped out, the amount of urine you excrete, and it also doesn't affect the pH of the urine. But in hypercalcemia, it can have an effect. Then also here you're going to see this is the Kassar receptor again. This is the G protein that's attached to it, and that's how it has its action. So when calcium is bound, it basically prevents anything from happening. Whenever it unbinds, that's what activates everything and causes the release of parathyroid hormone. So here's calcitriol excess is our next thing. So this is vitamin D, the active vitamin D. Granulomatous diseases are the first thing that we're going to think of, or not the first thing you think of, but the first thing I've listed here. Granulomatous diseases include sarcoidosis, tuberculosis, silicosis. You also have lymphomas, and then vitamin D intoxication. Now here's my advice. Stop taking all those vitamins. Excess calcium ingestion, so this happened a lot before proton pump inhibitors and other forms of treating gastric acid. Now it's less common, except for in the elderly who are taking calcium supplements to prevent osteoporosis. So milk alkali syndrome, this is basically just taking too much calcium in the form of an antacid. So then you have parenteral nutrition. I'll repeat myself. Stop taking all those vitamins. They're going to kill you. And I mean, I'm saying that tongue-in-cheek. Vitamins may be good, they may be bad, but too much of anything is bad. So excess thyroid hormone. You have hyperthyroidism. Now, hear me right. I did not say parathyroid. I said thyroid. So excess T3 and T4 can cause bone resorption. Other endocrine problems: adrenal insufficiency, adrenal crisis, pheochromocytoma, vipoma. These are related to these in some cases can cause hypercalcemia. Okay, hormone independent. These are kind of neat. Lytic skeletal metastases. So you basically have a cancer in the bone. It's causing the bone to just break down and send calcium everywhere. Immobilization. You don't move for a long time. You're going to get your bone being, you're going to have, so pressure on the bones. The osteoblasts have pressure sensors of some kind that they can feel whenever your bones are active, and whenever they don't feel that, they basically turn off, and the osteoclast activity shoots calcium out into your blood. Paget's disease. Then you have medications. So let's take a look at the medications. First is thiazide diuretics. Thiazide diuretics do not typically cause hypercalcemia. However, they can unmask a borderline hypercalcemia and make it worse. So it's acting on the kidney tubule. Then we have vitamin A. It's only 11 or 12 cases since 1953. So I saw vitamin A listed in one of the textbooks I was looking at. So I decided to do a little bit of digging to see what the mechanism was. And one of the research papers I saw written in the early 90s said that they had only seen 11 other cases of this. And I'm assuming that paper was the 12th case. So antiestrogens. This is acting on bone modeling. So if you take estrogen, that prevents osteoporosis. If you have an anti-estrogen, it prevents the prevention of osteoporosis. Okay, diagnostics. I got this from the diagnostic textbook. It's basically a shortened view, but I like Dr. Eric's diagnostic algorithm a little bit better. So here's basically what he has. The first thing you do is you're going to correct for low albumin. So the albumin concentration is going to affect the measured calcium. And so you want to find what the real calcium is based on the albumin level. And this is the basic formula, pretty simple. Then he also says the next thing to do is get a chest x-ray. I haven't found any other textbooks that actually say that, but he gave a great reasoning for that. And that's because the probability of finding some type of metastasis is pretty high. And then also if there's a hyperplasia of the parathyroid, you may also pick that up as well. But the main thing is to look for metastases in the x-ray, and fairly inexpensive. Okay, so then after you do that, you're going to measure your PTH, and the algorithm basically goes from there. If PTH is low or normal, or if it's high or high normal. And of course you can go through it and read it, just pause the video. Okay, clinical manifestations of hypocalcemia. I'm going to give you two pictures. I hope you remember them forever. Running man with lipstick and a weightlifter with lipstick. Why that? Well, the running man with lipstick, you're going to have running. That's shortness of breath and diaphoresis. That's what you get when you're running. That's also what you get when you're hypocalcemic. Lipstick, because you have perioral paresthesias. So perioral paresthesia, shortness of breath, diaphoresis. The shortness of breath is typically from spasms of the diaphragm. Then with the weightlifter, it's because you get muscle stiffness, spasms, or cramps. So basically you think you just finished lifting, you just finished doing 3 sets of 280 pounds on the bench. You're going to have cramps. Okay, clinical and other clinical manifestations. You can do specific physical exams. One includes the Voss-Teck sign, and that's tapping on the 7th cranial nerve and watching for a flinch or a spasm in the same side of the face. However, 10% of people have this without any disease at all, and so how specific and sensitive it is, I wasn't able to find. So tapping on the facial nerve anterior to the ear, get a facial spasm. Then you have Trousseau's sign, is inflating a blood pressure cuff to above the systolic blood pressure, so you're stopping the blood flow, and you do that for 3 minutes. And if their hand starts to basically curl in, their thumb starts to deviate, and their basically just looks like this, that's Trousseau's sign. The thing is, some people aren't going to like that, so actually I like a couple sources said not very patient-centered. I don't know. It's going to depend on your patient, I think. And then with hypercalcemia, short QT interval, hypocalcemia, long QT interval. Okay, again, if you have a failure of calcitriol at any point, if you have a failure of PTH at any point, and for any reason, so whether PTH isn't working on its receptor or whether PTH isn't being produced, whether calcitriol, vitamin D, isn't working on its receptor, whether it isn't being reduced, whether it isn't being absorbed, those are whether it is not being activated in the kidney, 1-alpha hydroxylase deficiency, and then of course calcitonin, not important. Okay, we have two big classifications of hypocalcemia. You can have low parathyroid hormone or you can have high parathyroid hormone. High parathyroid hormone is called, includes secondary hyperparathyroidism. So going through these, you can have agenesis of the parathyroid gland, destruction of the parathyroid gland, and reduced function in the parathyroid gland. And so these all have to do with the parathyroid gland itself, and then these other things. So you can have a vitamin D deficiency, PTH resistance, drugs, and other. So parathyroid agenesis, DiGeorge syndrome, you can remember that by, so it causes hypocalcemia, and it's typically the first symptom that becomes really concerning after the child is born. But it's a deletion of 22q11.2, and catch-22 is the mnemonic. So you get cardiac abnormalities. Usually you're going to have abnormal face, thymic aplasia, cleft lip, and hypocalcemia. So there's your catch-22. Then you can also have an isolated agenesis or dysgenesis, and this is usually a mutation of the PAX8 gene. Parathyroid destruction, that's just what it sounds like. Your parathyroid is being hurt or removed by something. I have the big radiation symbol here. Radiation is one of the big causes of that. And it's not radiation of the parathyroid gland, it's radiation of the thyroid gland. So if you have a tumor in the thyroid gland and you're using radioactive iodine to treat it, then it can actually hurt the parathyroid gland. You can have surgical removal, autoimmune, and then you can have infiltration from metastases. Okay, parathyroid reduced function. Again, we're talking about receptors. So hypomagnesemia. So this is saying basically the thyroid isn't working. And the reason that is, this Kassar receptor that we talked about already, it requires a normal amount of magnesium to properly function. So if you're hypomagnesemic, it's going to not work properly. So normal magnesium, I just said. Okay, so vitamin D deficiency is the next thing. And over here I have a picture of a couple of kids. They all have rickets. So you can have nutritional or sun. And so dietary, it can not only be dietary, but it can also be failure to absorb. And renal insufficiency is so there's a secondary hyperparathyroidism, and whenever it presents with a number of other symptoms, it's called chronic kidney disease, mineral and bone disorder. Then there's a 1-alpha hydroxylase deficiency, and you can get this from a deactivating mutation and you can also get this from hypophosphatemia. Hyperphosphatemia. So phosphate is a feedback on 1-alpha hydroxylase. It's negative feedback, and whenever you're hyperphosphatemic, you will turn that enzyme off, and you can become vitamin D deficient. Vitamin D resistance, so this includes many kinds of receptor defects. So this would be vitamin D resistant rickets, vitamin D metabolism. So with vitamin D metabolism, you can have drugs. So phenytoin will actually enhance the P450 degradation of vitamin D. Ketoconazole can also cause problems with vitamin D metabolism. So we have PTH resistance. So we already talked about that PTH is created whenever it's created and exported when calcium is not bound to the Kassar receptor. Well, now PTH also has its own receptors. There's receptors in most of the body, specifically kidneys, bones, etc. And then there's other receptors that are in the brain. So the receptors in most of the body are GS, and the receptors in the brain typically are GQ. You can also have a G protein mutation. So you can have a mutation in this receptor itself, or you can have a mutation in any part of this alpha, beta, gamma, G protein complex. So this would be called pseudo-hypoparathyroidism. Drugs. We talked about vitamin D drugs, phenytoin, ketoconazole. So there's also calcium chelators, and then bone resorption inhibitors. Bone resorption inhibitors like bisphosphonates, these are used to treat hyperparathyroidism. Then miscellaneous. So acute pancreatitis, and what happens here is whenever you have pancreatitis, you are getting soapy fats in the pancreas, and calcium deposits in those pancreatic fats, part of the saponification process. Hungry bone syndrome, if you have your parathyroid gland removed, then you will get hungry bone syndrome, where it starts laying down and depositing more bony material, calcium into the bone. And so this is important when a parathyroid is removed, specifically when all of the parathyroid glands are removed typically. Then we have osteoblastic metastases, and so what happens here, which is different than the osteolytic, is that it's stimulating bone formation, and this is really common in prostate cancer. Acute rhabdomyolysis, acute respiratory alkalosis, and so remember with alkalosis, most of calcium is bound to a G protein coupled, it's bound to albumin. I don't know what I was saying there. So we have albumin here, and usually we have calcium bound to it, and then it also has hydrogen ions bound to it. Whenever you're not having any of these hydrogen ions anymore, then the free calcium will bind to this as well. So this is going to be an acute thing, and it won't last into chronic conditions, because the parathyroid hormone will make up for that. Diagnosis, this again is from the algorithmic diagnostic book. Again, it's not very robust, but you can get a basic idea of what's going on without boiling down to exactly what is happening. However, Up to Date has a great way of doing it, and they just basically, first correcting for the calcium for the low albumin if it's there, and then taking a measurement of PTH, taking a measurement of calcium, phosphate, magnesium, vitamin D2, vitamin D3, and creatinine. Get those measurements, and then just look and see which one of these does it match. Of course, you could basically redo this chart by yourself if you just think through the effect of each of these things and what it has on everything. But of course, then the chart's there for you as well.